So before I go into the talk, I have some disclaimers to make as well as some housekeeping kind of things. I am employed by Aventar as Senior Director of R&D, Innovation, Cell and Gene Therapy, Biopharma and Production. But this work that I'm going to present today is a summary of a lot of the work that I have done in my previous positions, and all the information is public. So it is none of the, and it is not done, and this particular work is not done at Aventar. So with that, I think regarding the, first of all, I have some, before I forget, few thanks to people. Thanks for all of you for joining, sparing your family time on a Saturday and the weekend. And then to Professor Redana for the opportunity, and to Deepika and Srinivas for facilitating a lot of things that are required in this kind of requirements. With that, what I'm going to do is cover a little bit of basics for CAR T therapy. And I'm not a clinician by myself, but I want to make sure that everyone understands this. So I have kept the talk to a very basic minimal science as much as possible. For hardcore immunologists who are on the audience, it might look like a very flaky. So please bear with me for the simplicity. So what I'm going to do the introduction is, what is CAR T cell therapy and how does the treatment process takes place? What are the advanced incidents associated with this CAR T therapy? And would there be an allogenic model approach for this? Which means the current CAR T therapies are all autologous. For those of you, autologous is cells taken from one individual, treat them outside, and then put them back in the same patient. So there is no graft rejection. There is no any kind of issues associated with immunology. On the other hand, allogenic is a model in which from a healthy donor cells are taken, then they are engineered or expanded or exposed to cytokines, and then put them back in different patients for treatment conditions. Each of them have their own advantages and disadvantages we will go through. And what are the main manufacturing and challenges that are associated with therapy? And currently, CAR T therapy is roughly about $450,000 in US for one patient for one treatment. So followed by that, we'll do some conclusions. So that if you look at the treatment approaches, each cancer is different. Cancer, even though is one kind of disease, all associated with the cell division, but it exists in many forms. And for the current research so far, for some of the cancers, hormone therapy is used. And if it is a solid tumor, ectopic, surgery is used. And if it is blood related or bone marrow related, so it is bone marrow transplantation is done. And in all of these conditions, chemotherapy is done. And in few cases, there is, for example, breast cancer and all that, there is targeted therapy with the HEP2 antibodies, defining antibodies. And in few other cases, radiation therapy works for this. But let's hope all of them work for many of them. But there are other cancers that are recalcitrant. What I mean by recalcitrant is they recurringly occur, and none of these treatments work there. So that's where the immunotherapy comes into picture that has developed recently over the last decade. So that's why the importance of immunotherapy. When everything else fails, it is the only option that is left currently. So before I go into CAR T, I want to just get everyone on the baseline of what is that our immune system to respond with. So let's take, for example, if one is exposed to a virus or some other carcinogen. So what happens in the human body, the immunology kind of thing that I'm speaking about, is what is called as innate immunity will kick in. So innate immunity, that shows this blue line that is there, it goes up a peak and then drops back by 10 to 14 days time. And what is happening in that case is, for example, you must have heard from doctors, oh, it is a viral fever, you just don't take any medicines, take rest and fluids, you'll get away with. And that's where innate immunity is working. And this innate immunity is facilitated by first-line defensors, which are like natural killer cells, dendritic cells, macrophages, and then complement, neutrophils, eosinophils, all this kind of cell types. But while that is taking place, let's say if it is more than virus, and if it is a serious carcinogen that is doing it, the what is called as adaptive immunity also kicks in. And in this kind of adaptive immunity, the real T cells, the real immune cells, and B cells, they get into the picture. And what is not able to resolve by innate immunity will be resolved by adaptive immunity. So which means the T cell, this is called adaptive immunity because over the time, it has to take place. It will not take place soon after you are exposed. So therefore, the innate and adaptive immunity systems, both of them, they have to work together to tackle the virus or the carcinogens. And once this rhythm is disrupted, it can lead to quite a bit of viral spread. Viral will dominate. There will be hyperinflammation in the human body, leading to a kind of either cancer, pre-cancer, some of this kind of condition. So this is what is happening in those days when the T cells, look at this, when the T cells also drop off, when they resolve the tumor or virus infection, they are not touching the bottom zero, right? They are leaving a little bit of gap there, which means there are memory cells. So to bring you back an example, we all have taken COVID antibodies, COVID treatments and vaccines. So what it does is it resolves the infection. Not only the viral infection is resolved, a kind of T cell memory is retained. So the reason for that is when next time, when over a year time or 3-year time, if you are exposed to the same antigen again, so there is a similar response like this at that point of time. So that is the why the T memory cells are very, very important in that manner. So CAR T cell, what is CAR T cell? So the T cells are lymphocytes. Most of you might know that. This is a type of white blood cell. Now, when you go to hospital, they'll the WBC count and all that. So T cells are one of those white blood cell types that fight infection, and it is a part of the immune system. And what is a CAR? CAR is a chimeric antigen receptor. It's a kind of new protein. So most of these T cells have receptors, TCR, they are called TCRs. The ends of these receptors can be engineered, and you bring a chimeric antigen receptor. The name came because basically the red part that is shown is being synthesized completely, and that is being synthesized in tune with an antigen that is present on the tumor. So, therefore, since you have to engineer this particular receptor part, and this is a chimeric basically because chimera actually means, in literal terms, you have a human body, you have a human head, human body, goat body, and then a tail, something like that. It's a mixture of an organism. In reality, it doesn't exist. So therefore, it is synthesized. So this receptor is clearly synthesized to suit and to bind to that specific tumor antigen. So therefore, CAR T cell therapy is a gene therapy, not just a simple cell therapy. It is a gene therapy because the genes in the patient or T cells have to be reprogrammed to make those chimeric antigen receptor molecules to bind. So what will happen in this case of scenario is, if you generate those CARs and decorate them with all the T cells, then you call them as CAR T cell. Right? This CAR T cell then in case, this CAR T cell that is decorated with the CAR molecule to a specific antigen, it can bind specifically to that receptor, to that antigen that is present on the tumor surface, and then kill that tumor cell. So that is the real simple, the mechanism explained in simple terms. The website that gives you a little more details, I would recommend you to go through that. So the CAR T cells target the cancer. It is a targeted mechanism like lock and key, as I mentioned earlier. So a little closer look. So if you take a closer look, what is happening in this case is the CAR T cell interacts with the antigen positive tumor cell. Look at this, what is happening here. The CAR T cells create what is called as a granzyme and perforin axis for effective and specific lysis of the cancer cell. So basically, it is like ammunition works like create pores into cancer cell and then kill it by specific lysis. That's one of the actions that is taking place specifically on this CAR T. It also exerts secondarily two other effects which are really good. So what is happening, the CAR T, where the T cells are present and the cancer is present, is a war zone, is a kind of, immunologically, it is a war zone. So in this kind of war zone, if CAR T cell is trying to kill the tumor cell is trying to overcome that kind of killing and want to escape some of those. And the tumor what is called as the stromal cell, which is a tumor kind of microenvironment. So in this kind of thing, CAR T cells derived cytokines can, so the CAR T cell also has a cytokine domain, which sensitizes the tumor stroma. So by sensitizing, it regulates the stromal cells targeting interferon gamma. So it is specifically interferon gamma and interferon alpha receptor, they're all involved with the stromal cells in the tumor microenvironment. So the other aspect that also happens in the antigen negative tumor cell. So there are, so real tumor specific antigen is a myth in the sense that it is also called as tumor associated antigens. Basically, because if you target one receptor or one antigen, the tumor should eradicate, but that is not the case in reality. So there are some antigen negative cells, tumor cells. So if the tumor is the same, it looks the same morphologically, but there are some antigen positive and antigen negative cells. So this kind of antigen positive milieu, the antigen negative fraction can be targeted by CAR T cells by Fas and Fas ligand axis. You all know Fas and Fas ligand axis by the apoptotic mechanisms. So the mechanisms are so multifarious. It causes lysis in the positive tumor cells. It modulates the microenvironment. It also causes lysis of the antigen negative tumor cells.